Hello and welcome to Chapter 7, or welcome back to Chapter 7. When I lectured on Friday, June 26th, this is where all three groups left off right before we started talking about nasal steroids. So I will finish this chapter and then I will go back and do the first part again for people who were not able to be there that day. That way, whoever's already heard the lecture can just move on if they need to. So on page 113 in the textbook, we start talking about steroids that you can use in your nose for nasal congestion and allergy symptoms. Corticosteroids, which we just call steroids, usually cortisone or hydrocortisone, some form of that, some synthetic form of that, work directly on the immune system to kind of suppress immune function. And in this way, they stop you from reacting to certain allergens. They also can make your nasal passages and your bronchial passages a little bit less likely to overreact when it runs into a foreign protein. So steroids will work all throughout the immune system to inhibit the production of all those chemical messengers that we've talked about. They're going to inhibit cytokine production, and that's what gives you many times the big immune system reaction or overreaction sometimes. It blocks the activation of various kind of proteins that respond in reaction to inflammation, and they keep those inflammatory cells from migrating to the site of action. So you can use steroids in a nasal inhaler to squirt up your nose, usually once or twice a day, and just suppress any immune system reaction that centers in those nasal passages. Or you can take steroids systemically, usually in a PO form, like a dose pack, prednisone dose pack. Sometimes in emergent situations with really bad asthma attacks or COPD exacerbations, you will take steroids IV. And they help you to get a quicker handle on inflammatory reactions. Usually they'll start off IV if you're trying to have a quick recovery from a very severe episode. And then we'll usually change to PO, or they'll just start with PO, especially if you have to be on them for a long time. These anti-inflammatory or steroid drugs will work to reduce nasal congestion right at the site. And so you can use those to treat allergic reactions. They can use them to block those mechanical reactions when you have non-allergic rhinitis. If you have medication-induced nasal stuffiness, sometimes that will help that. Or nasal polyps, which are like overgrowths of tissue, usually from constant nasal irritation. If nasal polyps, they're almost like skin tags, and they grow on the inside of the nasal passages, and they can get pretty big and block you from being able to breathe. And sometimes steroids will work to make those shrink, especially if any other kind of treatment hasn't worked as well. Sometimes steroids can produce a rebound asthma reaction, although that's pretty rare. It can make your head hurt, or you can kind of feel dizzy. The biggest complaint about nasal steroids is over a period of time, your nose gets very irritated. Sometimes you can have your sense of smell affected, and it can make your nose bleed. In severe cases, you can perforate the nasal septum because repeated use of steroids makes the tissues very thin. We know that steroid use stretches and thins tissues. And so you have to be really careful when it comes to these steroids. Usually you're going to get checked pretty often to make sure you're tolerating them well. Now, we're going to move on to two conditions, asthma and COPD, and the different kinds of medications and treatments that will help with those. Now, asthma and COPD are very different from each other. and we're going to see why here. With asthma, your bronchial passages usually react in an inflammatory manner to some sort of real or perceived foreign protein. Many times, like nasal allergies, the immune system hyperreacts to things that other people wouldn't be bothered by. When this happens, you've got that inflammation that we talked about, that swelling, and then increased mucus production. So not only do you have the tissues swelling and the bronchial passages becoming tighter, but you also have mucus production that clogs up the bronchial passages. You can get air into your lungs, but it becomes more difficult to breathe out. And you'll hear a wheezing sound, kind of that musical wheezing sound, because you're trying to get air to go through those narrowed passages. On page 114, there's a little cartoon of what happens with narrowed airways. And on page 115, 7.3, there's a step system for how they categorize asthma, whether it's mild, intermittent and persistent, or moderate, persistent, or severe, persistent, where you end up usually hospitalized. On page 114, make sure you read that memory jogger about how the bronchoconstriction happens. It gets inflamed from the inside, and then as the bronchial passages constrict, that narrows the airways from the outside. So you kind of have a double whammy, plus filling up with mucus. And mucus production is natural. The body tries to produce mucus to catch any foreign invaders, but with asthma, you kind of react to things that aren't really there, and there's really nothing that needs to be trapped, but your body reacts anyway. So here is a little representation. On the left side, you see the normal-sized bronchial passages. The muscles remain dilated, and air goes in and out easier. When you have inflammation, you can see that all those mucous membranes inside the bronchial passages swell, and so it's hard to get air out, especially. And then when you add extra mucus production, you're just sort of hit from all sides, and it makes it very difficult to breathe, very uncomfortable, and very scary. Now, COPD is different. When we talk about COPD, we're talking about two conditions. We're mostly talking about emphysema, but you can also have chronic bronchitis, where your bronchial passages just stay permanently inflamed and swollen, and they want to produce a lot of extra mucus. With emphysema, the walls of the alveoli are destroyed. Remember how I talked earlier about how the alveoli and all the capillaries that surround them are responsible for exchange of oxygen and carbon dioxide, and you cannot do that when the alveoli begin to rupture.